Hello everyone, I'm So-Ick Jang from Sejong General Hospital, Korea. I'm greatly honored to be here as a speaker. Today my talk is the Percutaneous pulmonary valve implantation related complication. Dr. Bonhoeffer et al. Initially described the transcatheter pulmonary valve replacement for alveolar conduit dysfunction in 2000. The transcatheter pulmonary valve implantation has been widely accepted for attractive alternatives to surgical PVR. Until now, there are various kinds of percutaneous pulmonary valve systems, but today I focus on melody valve and Pulsta valve. This report is post-market surveillance to detect adverse events associated with melody valve implantation. They searched adverse events in on-label and off-label use. Main procedure-related adverse events were vascular access complication, conduit rupture, coronary compression, and VT. The ballooning and PPVI instant release bioprocess valve or conduit is relatively high risk for conduit tear or rupture. The conduit rupture is one of the most dangerous complications that need urgent treatment. Therefore, prevention is the best treatment. So we need careful review of surgical record to determine conduit character and normal conduit size. Also, serial and careful dilation with without cover stent is essential. Coronary compression occurs due to proximity of implant area to coronary anatomy, especially in native alveoli or conduit. The balloon test with simultaneous arterography or selective coronary artery angiography reduces the risk of coronary artery compression. However, there are some reports about the late coronary complication after PPVI. The documented risk factors for coronary artery compression are congenital coronary anomaly, tetralogy follow, and transposition of the greater arteries, patients with reimplanted coronary ostia, such as the loss procedure, abnormal relationship of alveoli and coronary artery, and any of the combination of above factors. Even though negative balloon test, aggressive pre-dilation and post-pre-stenting and post-dilation make compression of coronary artery. So ballooning post-sizing test should be chosen based on the valve intended to implant very carefully. In addition, the self-expandable system, as like Pulsta valve, have the property of chronic dilation with low radial force. So although there is no coronary problem during procedure, it can make a late coronary problem. Therefore, we must check the chest PA lateral and electrocardiography regularly. From early report of Bonhoeffer group, they showed excellent early outcome. However, the freedom from surgical explantation was not satisfactory. The freedom from surgical explantation was 89% at 6 months and 70% at 36 months, and they reported important PPVI-related complications: conduit rupture, dissection, embolization or dislodgement, stent fracture, and infective endocarditis. The early report of US melody valve trial showed equal high success rate and excellent valve function. However, the freedom of stent fracture was also not satisfactory. The freedom from stent fracture at 14 months was only 78%. From this early result, the stent fracture had been considered one of the most important risk factors for valve longevity and reintervention. And from multivariable analysis, we found that the implantation within any intact pre-stent or bioprocess valve could protect the stent fracture. Therefore, pre-stenting with conduit with bare metal stent or cover stent before TPV placement has become routine at many centers. Another important procedure complication is infective endocarditis. From French registry, the cumulative infective endocarditis incidence was 12%, and analyzed infective endocarditis incidence was 3.6%. Also, aspirin discontinuation was statistically associated with severe infective endocarditis. In addition, the mortality and cardiovascular events were significantly associated with in infective endocarditis group. Therefore, the true therapeutic education cannot be overemphasized before and after implantation. From US multicenter trial, freedom from a diagnosis of endocarditis was 89% and freedom from TPV-related endocarditis was 92% at 5 years. Most common organisms are S. aureus, Leiden streptococcus, and coagulation-negative staphylococcus. By multivariable analysis, age less than 12 years at implant and immediate post-implant peak pressure gradient to more than 15 mm mercury were associated with development endocarditis and with the development TPV-related endocarditis. Another large report showed the importance of residual alveolar pressure gradient. Therefore, we need aggressive predilation, pre-stenting, and post-dilation to achieve maximum relief of alveolar obstruction at time of TPVR, taking into account potential complications such as coronary artery compression and conduit rupture. At the same time, thorough evaluation of infective endocarditis and education before procedure are needed. For Pulsta valve, one of the self-expandable pulmonary valve system for native alveoli showed an excellent midterm result. However, we have some experience of complications. In this case, we tried to implant on native alveoli using Pulsta valve. Using the valve partially flared, we tried to pull the valve, but valve was embolized in alveoli. Fortunately, we could retrieve the valve and could reimplant without complication. However, if a full flared valve embolized into alveoli, we have to remove surgically. Like this complication, PPVI in native alveoli is not always easy because of various alveoli morphology, especially pyramidal and reverse pyramidal shape have unstable landing zone and risk of slipping and embolization. Therefore, we have to implant not on ideal landing zone but on practical landing zone. Of course, repeated angiography during procedure is essential. Malod valve is also a tissue valve system from bovine jugular vein, so valve failure is inevitable. Main cause of reintervention were stenosis with without stent fracture, stenosis with infective endocarditis. Overall freedom from explant and from any subsequent alveolar reintervention after first reintervention was 83% and 60% at 4 years, respectively. And for method, lead TPVI show better outcome than simple balloon dilation. Freedom from reintervention and freedom from explant is better in lead TPVR than simple balloon dilation. Patients with initial reintervention was balloon dilation were more likely to undergo a second reintervention than those who had TPV in TPV, but there is no significant difference in freedom from explant. Freedom from any secondary intervention and freedom from TPV explant was longer in patients with initially underwent reintervention for stenosis with without stent fracture than patients in endocarditis. This is my take-home message. The PPVI is a very safe and attractive alternative to surgical PVR. However, there are critical complications as like conduit rupture, dissection, early and late coronary artery compression, stent fracture, infective endocarditis. So, careful review of surgical record and imaging evaluation are essential for predict the risk of complications. And ballooning post-sizing test should be chosen based on the valve intended to implant very cautiously. Also, before and after thorough education for infective endocarditis is paramount. In addition, the various alveolar morphology need well-tailored landing zone technique. Finally, regular and close follow-up for late complication is mandatory. Thank you for your attention.